So, if you're wondering where you're at, you have stumbled upon the 22 at the Lips podcast. However, you got here, I'm glad you're here. This is the podcast from EMS providers and healthcare providers in general to stated audience and bystanders and civilians and whoever you may be. Thank you for joining us. Today on the podcast, I have Meg Brazzel. I have permission to say that. Um, I've known Meg for a little bit. She's a really good person. I'm proud of her. She's in an area of the healthcare field that personally I don't think I could be in, but it's very commendable. She's done a lot of things in her field. I don't want to say outside of the field, but kind of what we'll talk about. A little more education. What's the word I'm looking for? Kind of more like awareness to parents about her area of specialty. And before I give too much away, Meg, if you want to tell the people who you are, what you stand for, the floor is all you.
Well, thanks for having me. I'm like super excited to be here with you, Alexis. It's awesome. I'm Meg. I am a pediatric ICU nurse. I have been working in the ICU for almost 5 years. And then about a year and a half ago, I started doing some like online education for parents on like what to do in an emergency, because it's unfortunate, but we live in a world where kids get sick and bad things happen, and unfortunately, kids die. And it's if I could do any bit of education, kind of like your podcast, to help people out, to either prevent or be there to support parents during those crazy, insane times. They're traumatic, and I want to help bridge that gap between medicine and parents. So, yeah.
And in that aspect of the area that you work in and stuff, not physical area, but like specialty, it is so hard. Like, it's hard in general with the people that we encounter that are sick, that are dying, or aren't and just need to ride at the hospital. But that's hard enough. But it is a different area when it's kids. And that's
Yeah.
what, even when we're going to a call and we get the notes that it's like, you know, I would say even like 16 and under, it kind of makes my chest hurt a little bit.
Yeah. That's what a lot of people think and are fearful of, because a lot of times these kids can't communicate what they're feeling or what's hurting or what happened. And it's so much easier when someone's able to communicate, oh, like my chest hurts.
For whatever reason, if you ask a 6-month-old, are you
Yeah.
hurting?
Yeah, like where does it hurt? And they're just like screaming their head off. Like, yeah.
Okay. So before we dive into our questions and our topic discussions, a
Hmm.
couple of rapid fire questions that I did not
Oh,
prepare you
Lord.
for.
Okay, let's go.
No pressure.
No pressure.
Number one, what is your favorite color and why?
Oh gosh, blue. Because I literally love the ocean. Can't help it. It's like my go-to. I need to decompress. The ocean is where I'm at. With red flags, that's it. It's not a near-death experience. I'm not here for it.
Honestly, like, space is scary, but I think the ocean is 10 times scarier.
Oh, I love it. I love it. Obsessed.
I think it's ever since I watched Jaws, it has
Oh, I
ruined
can't
me.
think about that. I watched Jaws on a big screen in a pool, and I still, like, when I go swimming in a pool, I'm like, take a deep breath.
Okay. Number 2. What is the craziest dream? Like sleeping dream. What is the craziest dream you've ever had?
Oh, Lord. Okay, so there's, like, the secondhand trauma stuff from work, but that's always one that gets me. Um, I well, I guess let me just go with that. So, I would wake up my first year of nursing, I would wake up in the middle of the night and, like, go for my husband's face, holding an ET tube, and, like, whole face, hold it in, like, as if he had an ET tube in, and he would freak out, and it was funny, but he'd have to, like, wake me up because I would have these, like, terrible nightmares about it. But, I still, like, sleep talk and stuff at night, and so he's learned, like, what to say to me to, like, get me to go back to sleep, meaning, like, "Don't worry, I got the IV, the dopamine has started, the" and so, like, he's learned what to say, and he's like, "Don't worry, I called the doctor, they said this blood pressure's fine, it's 120/80," and I'm like, "Okay, sounds good, I'm going back to sleep."
The unicorn is here. 120 over
Yeah, like
80.
yeah. He's definitely learned what to say, but, that's probably more common dreams. But
Which is fair. Question number 3. You have a day off of work and no scheduled plans. Are you staying at home and relaxing in your PJs all day? Are you like calling up a bunch of friends, having like a whole day out? What you doing?
Well, this entire week, I have stayed in my PJs all day, and I just got dressed for today. But I really have, like, stayed on the couch these last 3 or 4 days, mostly because 'cause we've had, like, a crazy couple of months, and I just needed a week off. But I do enjoy going out and doing top golf with some friends and going out to eat, building five, love it, it's my favorite, or shopping. So I do both,
Mhm.
but particularly this week I was at home.
I think there's no shame in like having like your week of just staying in your PJs, relaxing, taking it easy.
Hmm.
That's something I've learned the hard way, that just because you have a day of rest and relaxation, it doesn't mean you're lazy. It doesn't mean that you're
Yeah.
not doing anything productive. You need those days.
Yes. No. Oh Lord, I need those days. It's like, work just is draining sometimes. Like you give so much emotionally, you give so much mentally. And then there's like so many people and managing other people's emotions. It's not much fun. So sometimes you just need to like decompress.
100%. Especially for you, like dealing with all those parents.
Yeah. Yep. Yep. It's a lot. No, not downplaying that one at all.
That's like on our calls with kiddos and stuff. It's one thing that it's already like, you're dealing with the sick kid. Then it's another when it's the parent who, I mean, granted, it takes a lot to say, like, this is out of my hands. I don't know what to do. And then it's their kid on top of that. And so, like, their job is to provide for this child and take care of them. And now in this situation, they're unable to. So then
Mhm.
they're panicking. And for
Yeah.
me, honestly, I'm panicking too. So,
Too much panic going around. We just need to get to the hospital and I can pass this kid off.
exactly.
I know, I get that. I get that. Well, I'm stuck with them for 12 hours, so thanks.
Low
Just
key.
kidding.
If we ever have a kid, and obviously we're going to children's with them, it is such a sigh of relief. It's like we know what to do.
Yeah.
We have the capability to do our job and stuff. But when we can just show up, give report, pass the child on, and leave,
Yep. Yep.
maybe that's just me. But Okay. So tell me about your journey in the nursing field. So, like, why you began this career. Tell me
Mhm.
about your transition into the PICU, why you chose that specialty. Like, give me the whole spill.
Yeah, yeah, of course. So I knew I was going into nursing right away. I don't really know, there was never like a singular moment where I was like, oh yeah, I'm going into in nursing. I just kind of knew. I applied to school 18 years old, got in, graduated at 21 with my associate's degree, which I literally recommend everyone to get your associate's in nursing before getting your bachelor's, because you can start working about 2 years before as an RN, which is awesome. It's only 2.5 years to get your RN. Um, and I originally did not want to do pediatrics actually because I was like, these parents are crazy. They are wild. Like they are Googling things and they are insane. And then I had my pediatric clinical in school and I had this kid who fell off or I can't remember exactly what it was, treehouse that fell on him or something similar to that, right? He had nasty like ear cut off or something silly, like not silly, you mean like it was traumatic, right? He was fine. He wasn't intubated. He was like stable. It was just like they were monitoring overnight essentially in ICU. And I remember the parents being worried, but they trusted the team, the pediatric team that was taking care of it. And it like it changed my perspective on parents on like they can be grateful and they can actually pass off their worry and their trust into somebody else to help take care of their kid. And I remember I was there for a couple of days for my clinical rotation, and that kid went from being super sick in the ICU to like being like dancing in the room and having a good time. And I realized that like we get to see in pediatrics um, something terrible happen and then a complete turnaround, and you don't get that in adults. Something like a brain bleed can be devastating to an adult, whereas a kid can bounce back really fast. So that's what I fell in love with, is that you can see positive results at the end of it because kids are so resilient, and it's insane what they can accomplish and survive, and it doesn't make sense. And for something that would be so devastating and would mean death for an adult would be a success story for a kid. And so that's how I really got involved in pediatrics. I stayed at that hospital for 18 months or so, and then my husband and I moved to Baton Rouge, started at Children's Hospital here, and then I've been traveling now for 2 years around Louisiana, helping with like staffing crises and stuff at 4 different hospitals in Louisiana in their pediatric ICUs, and I love it. I love it so much. Every where you go, it's different, and they have different protocols, and you're learning from different hospitals, and you're learning from different staff who've been somewhere for years, and uh, it's it's also interesting because like Louisiana is so small, right? That you see something on Facebook and somebody posting about, oh my gosh, my kid, this happened or that happened. And depending on the area that I'm at, I'm like, oh, I'm gonna take care of that kid tonight because that's like if you end up in ICU, I'm probably you're gonna be your nurse, like if I'm headed into work. And so I it sounds silly enough, but I have taken care of like a lot of kids who have been like blown up on Facebook and like, oh, everybody's praying, everybody's sharing it, or there's like these giant GoFundMe is like probably taking care of your kid, taking care of that child. Which also gets very difficult when you start talking about HIPAA and oh, I have no idea who you talking about. I had no clue. You know what I mean?
Yeah. And that's like sometimes I want to tell people about like a specific call that we went on, just because it's like it was a good call. I want to get feedback and stuff like that.
Yeah.
But then I see the news article about it, and I'm like,
Mhm.
well, guess not. I'm gonna keep my mouth
Yeah.
shut.
Oh, yes. Oh, yeah. Oh, Lord, when those news articles come out and I get texts and I'm like, "Oh, I don't know." Uh, ooh, I don't know. You'll have to Google that one.
Right. Meanwhile, you're about to walk into that room with that kid.
Oh, meanwhile, yeah, and, sorry, a little side note on that, like, we get a lot of the kids here in Baton Rouge that have been, like, homicides or sex trafficked or, uh, some, e like, some rollover car accidents, blah, 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 where, there's a lot of, like, legal stuff with it, and we I mean, we know all of the details. We know everything. And, sometimes we're the ones reporting to DCFS and to the homicide group and, all these things, especially with non accidental traumas. These kids have been shaken or beaten, and like, we know all of that information. And uh, it's very like I can't imagine like y'all walking into one of those situations and picking up a kid because it's so hard to manage it from our side in the hospital. Like walking into that situation, I can't imagine for you guys.
I mean, that's one part of it, but like we can report things to DCFS and like elderly abuse and stuff like that because we see the initial scene and setting. But I feel like for y'all, it's the more extensive reporting and extensive process just because like y'all have more of a longer term versus ours is like, this is what we saw, and this is why we think it.
Mm-hmm. Yeah.
Yeah.
Mm.
So, um, tell me, you mentioned that you did like some cross training in the NICU.
Mm-hmm.
Like, was that, I mean, I guess, was it before the PICU? And
Yeah.
like, what does that entail?
Yeah. So, when you're in the hospital, you get floated to different departments all the time based on like staffing needs and stuff like that because we have strict ratios, especially in pediatrics and in uh, either ICU, say NICU or the pediatric ICU. Different hospitals have different requirements. The Generally as a PICU, I'm trained in PICU and then I float to the NICUs. Depending on my travel assignments, I might stay in the NICU for weeks and weeks and weeks. Again, it's all based on staffing issues, staffing needs. But we can still take, ventilators and stuff. Um, they try to give us lower acuity patients so that we're not necessarily like taking care of the sickest NICU babies. Some of the biggest things though is resuscitation is different for NICU babies versus pediatrics. Um, Pediatrics follows more on the ACLS standpoint versus NICU is you treat respiratory stuff before you treat cardiac stuff. So you bag the patient before you start compressions. Um, I mean, you still start compressions, but you attempt to bag because it's usually a respiratory failure rather than a cardiac failure for uh, NICU. And so that's pretty much the certification is different. And then also, I mean, NICU is like a lot very standardized. Like this kid at this age should be able to do this. If they're not doing this, then you do that. And like very minor changes. Versus pediatrics is a lot broader and you have a lot of different sicknesses and stuff like that. So did I answer that?
100%.
Did that make sense?
Yeah. No,
Okay.
and it's kind of like what we touched on before we started this recording. Um, these are two definitely not the same, elements of treatment and even medications and stuff, because especially like in resuscitation and at least for us, like the things we can do, and remembering that, like, my paramedic instructor said it, and she used to do flight. Um, but she talked about it's like per kilogram is like 1/10 of a milliliter, something like that. So like even when you're starting your IV and your flush, like you're having to count all of that. And it
Yes. Yeah.
stresses me out.
Yeah. It, it's pretty stressful. I hope that you guys aren't dealing with too many like less than 40 weeks gestation. Generally, if they're in that range, then you're gonna have like an NP or a nurse traveling with um, those NICU babies, and a respiratory therapist. Generally, like if you're transferring facilities or something like that. But I guess if you have a laboring mom that comes out and births the baby with you, which hopefully doesn't happen too often.
Not very,
Okay.
thankfully.
I'm glad. I would freak out. I would utterly freak out. I worked at one hospital where we had to cross train for like labor and delivery stuff, and oh, I was not there for that. I did a lot of tasking. I'm like, oh, you need a catheter. I got you. Like, I do not get that placenta near me. No, thank you. This baby's come out looking funky. I'm not for that one.
Oh, it is so I don't want to jinx myself. Knock
Yeah,
on wood.
careful.
But I'm not going to say the only one because that's very tempting. But I have delivered a baby in the back of an ambulance. And oh my gosh, we literally got underneath the ambulance bay when she gave her last final push. And I just remember like watching this whole process up close and personal in so many ways. Um, and she delivers this baby, and I'm holding it, and I was just like, what is supposed to be beautiful about this? And like this baby is covered in stuff. And this poor mom was just like laid back on the stretcher. She's 19, her first kid, and she was just exhausted. I was exhausted. This baby is exhausted. But no, we
Yeah,
don't deal with
yeah,
a lot of neonates. I know like it happens, some people do, but typically no.
yeah, yeah.
And then for us, it's a
Oh,
lot of just going back to your training of basic
keep them
components of
alive, pass them
CPR.
off. Yeah,
Exactly. Thankfully.
yeah. It's so funny. I love that.
I mean, granted, there's a lot of other stuff and whatnot, but gosh golly, compressions and ventilations really just they
Yeah.
save you.
Yep. Yep. It gets used in some place, okay?
Right.
No, I get that.
So, you like we talked about, you advocate a lot to educate parents in like the pediatric emergencies, like you talked about.
Mhm.
What made you want to start doing that? And like, do you have like a main goal for this endeavor of like having so many people that are aware of it, or like starting a book about it, or just raising the general awareness of if X happens, do Y and Z?
Yeah. Yeah. Um, I I have a couple of goals in mind in the next couple of years. Um, Currently I'm like trying to just focus on my career, but on the side I'm doing this. But I have held, and this is a little bit more, I guess, on the emotional side of things. I've held so many parents' hands and sat with them 2, 3 in the morning with them in tears. Like, what could I have done different? Why are we here in the ICU? Um, why is my kid on a ventilator? Is this life support? Are they going to make it? Do I need to start planning a funeral? Very heavy conversations at the middle of the night, right? And, you're not talking about a parent, you're talking about, a 3-year-old, you're talking about a 6-year-old. Um, these things that nobody plans for, you know what I mean? And I, I realized that parents either don't know when is something an emergency, um, or you have parents that are coming to emergency rooms that their kid isn't that sick, and then they're frustrated with medical care that they're there for 2 3 days, or they're stuck in an ER, they're transferred to another ER, and they never get admitted. It's like, well, then I just wasted all this time. My kid's in the hospital, they could have contracted something else while they're here. Frustration on both sides. And if I can provide any type of support for these parents on either what to do quickly or when to recognize that something is beyond capable to take care of themselves, then I'm going to do that. And I'm going to talk about it. And I'm going to be annoying about it because I had one parent joke with me saying, well, I hope my kid has an emergency so I can use your information. And it's like, that's like, I'm glad you're supportive. But if I can repeat it, so many times, like, as something as basic as CPR on, how to check a pulse, or when to recognize respiratory distress, because if you can recognize it, several days before, because kids can compensate for a long time, you can recognize something several days before, we can get them treatment in a pediatric office way before they're needing to be intubated on a ventilator in the ICU. Sometimes it happens, and that's where people end up, and that's where kids end up. But there's a lot of things you can do before you get to an ICU, especially in kids, to prevent further harm or those things. Does that make sense?
No, 100%.
Yeah.
Um, I appreciate the content you put out. Like, it's stuff that, like, we've been trained in and stuff like that in the emergency field, but it's kind of good, like, to have those refreshing moments of, like, if it's a kid that's drowned, something that
Mhm.
we typically don't encounter, but, like, this is what you do, and then we build off of, like, those aspects. I also appreciate it because I feel like it has soothed my sister-in-law with my nephew, who already had a lot of fear when Atlas was very teeny, and, like, still she'll be like, "Oh, well, Meg told me to do this. This is how to check for if Atlas is having an allergic reaction to a food." So, I appreciate
Yeah.
it.
Yeah. Yeah. There's a lot of new parents, and when an example, like, I get floated to the NICU, like we were just talking about, and parents are so fearful, and especially with, like, is my kid gonna stop breathing? Is SIDS real? What happens when someone drowns? Those are pretty much the three biggest things that parents are fearful of. Um, no matter how long they've had a kid or how long they've been a parent, like, those are real fears, and unfortunately these are real things that happen. Um, and so any bit of anxiety reducing things that I can say or do, I'm gonna do it. No matter how annoying it it starts to get, there's gonna be somebody out there that's gonna appreciate it eventually down the road.
I don't think it's annoying. Um, I actually have a couple of friends that I turned them your way, if that makes sense,
Mm.
and kinda, like, showed them what you do and what you talk about, and they follow you too, so I don't
Oh,
think it's annoying, and I appreciate it. We all appreciate what you're doing.
thank you. Thank you.
Um, okay. So, I don't want to say that nursing and EMS are two completely different things because at the core, it's not. We
Yeah.
have our training, we have the aspect of patient care and
Mhm.
the bystanders and family. Um, and just like even some of the meds that we carry are still the same as in the hospital setting.
Mhm.
However, um, what would you want to tell like the emergency medical providers in the field concerning specifically like infants and pediatrics? Because like I said, like we're trained in these age groups, but from a nursing standpoint and the longer term care, like
Mhm.
what is something you would say?
Yeah. So this is talking about parents, right? They're going to be your biggest advocates for the kids. Um, Meaning, if they can calm, like you're a stranger, right? You're a stranger. You're touching them. You're doing things. Um, you're the parent. Like you can get more done with a parent holding a child, and instead of them like wide open and flailing in, say, your ambulance bay, like a parent holding a child is going to get you way further in getting things done, um, like physically, medically, and stuff like that. Getting them to manage the child and their emotions while you can handle the medical is going to be your best best thing for you when managing with kids. Um, and then so whenever I was like reviewing these questions, I had just listened to a podcast from um, Allison Stoner. She just released one called Dear Hollywood, and she was talking about um, how they, as small kids are getting their makeup done, someone's touching them and someone's putting a mic on them, and they're going underneath their shirt, underneath their pants, and they're getting undressed. And I was like we literally do that, and we don't ask permission all the time to touch these kids. And we forget it because we are very much in our profession, and we are very much got to do what I got to do. And you try your best to remember to do those things, but as a reminder, like these are kids, and we have to maintain their modesty, and we have to maintain permission. Um and I mean, it's one thing for, I don't want to say it's one thing, but like, you have toddlers and younger, they don't really understand, but like anything older than that, they understand that you're a stranger touching them. And we have to tell them what we're doing. We have to explain it on the developmental age. I am just gonna, put these stickers on you. Don't you like stickers? Blah blah blah. Um, talking about your EKG leads or getting your pulse ox or all those things. Like, I'm not gonna touch you down there. Don't worry. I'm just gonna do this. I'm just gonna touch your shoulder. I'm just gonna put the sticker right on your back or whatever the thing is. I know you're scared. Like really talking to them. Um, and acknowledging that, they're a child and we have to respect their bodies. Um, that is something that, gosh, we were intubating a kid a couple weeks ago, and uh, the kid, 15, 16-year-old, crashed really, really quickly. And so we ended up taking off blankets, taking off sheets, all the things. And someone forgot to pull um, the curtain back. And how simple is that, right? Like,
Mm.
we're exposed. We have a 16-year-old who's completely exposed. Like, we can maintain modesty in this situation. We don't need to be seeing everything this very second. Um, it's it's hard to remember that whenever we're in that like strict mode. We get there. I mean, like when you have someone crashing, you have someone crashing. Like you got to do what you got to do to save their life, but try to remember to maintain some type of modesty for them, especially in kids. Does that make sense?
Yeah. And the part about like the parent being the advocate for the child, especially like those special populations of these pediatric kiddos and stuff like that. If you have that kid with like the extensive medical history and is trait and is whatever, you've never met this child. However, this parent has been with this child from the very beginning.
Yeah.
So I know providers that they're like, oh God, the parent was all up in my way. I'm like, please hold your child.
Yeah.
Please talk to your child. And like,
Yeah.
you know way more than I do about this kid. Like, whatever
Mhm.
you say, by all means, have at it. Um, and another thing that like I've kind of adopted, um, it was actually this partner that I worked with. Um, I think we had a call for it was like a kiddo, and it was the parent's first kid. And the way they were freaking out, which granted is their kid, I get it, but it was not an actual emergency. Like it just
Yeah.
the kid was fine.
Mhm.
And so I had asked, I was like, is this your first kid? And my partner shot me this dirty look. So I didn't say nothing for the rest of that entire call.
Yeah.
So like after, I was like, dude, what was your deal? And he was like, there's a reason I don't ask parents if it's their first kid. He was like, because when you get to the hospital, which it had happened with him and his kid, and the doctor's like, oh, is this your first kid? It kind of is this already underlying tone of like, you're freaking out for no reason just because it's your
Yeah.
first kid.
Yeah.
So that's something that I've adopted, and I I don't think I've ever asked this then, because I'm like, even if it's your first kid or it's like your, I don't know, you got busy and it's like your 10th kid, like
Yeah.
it's still the same thing of you're freaked out
Yeah.
about your kid.
Yeah. What we think is an emergency is often so much on the far side, dramatic side, than, you know, and this is I talk about this all the time, but fevers, parents freak out over fevers, and it's a fever. It's hard, but it's an emergency to them, and we are not only managing a kid, but we also got to manage the family and their anxiety and what comes with that. So
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.